Okay, I think we're about ready to get started. Welcome everyone to this Glowderm session on HIV in Sub-Saharan Africa, lessons learned with our speakers Dr. Anisa Mosam and Dr. Julio Ribeiro. Today's webinar is hosted by the Glowderm Trainee Committee. I'm Dr. Chloe Salas. I'll be one of your hosts today, in addition to my fantastic co-hosts, Natalie Assemi and Sabali. A little bit about the Glowderm Trainee Committee. We are part of the International Alliance for Global Health, for Global Health Dermatology under the International League of Dermatological Societies. Our mission is to promote knowledge equity by enhancing access to dermatology education worldwide. And our key initiatives listed here included educational webinars, which you're a part of, these free and high quality learning opportunities, networking and collaboration, connecting trainees worldwide. And we also have a podcast series that you should check out called Addressing Challenges in Global Health Dermatology. Just some brief meeting etiquette. Your audio will be muted and your camera will be turned off for the duration of this webinar, which you probably already noticed. Please feel free to submit any questions via the chat or the QA function, and our meeting host will share these with the speakers to answer at the end of the webinar. And we will be sharing further information about the Glowderm Trainee Committee in the chat function, so make sure to keep an eye on that throughout. So now I'll go ahead and introduce our speakers. First, we have Dr. Anisa Mosam. Dr. or Professor Anisa Mosam is an associate professor in the Department of Dermatology at the Nelson R. Mandela School of Medicine and head clinical unit at Nkosi Albert Luthuli Central Hospital. She has practiced dermatology for almost 3 decades, both in public and in limited private settings, and the following are areas of interest: HIV/AIDS dermatoses, autoimmune bullous diseases, and psoriasis. In addition to her research and clinical service, she's also dedicated to training and teaching of undergraduates and postgraduates, in addition to allied disciplines. She's co-authored and edited an atlas of skin conditions associated with HIV/AIDS and a comprehensive textbook of skin diseases in Africa. Next, I'll introduce Dr. Julio Ribeiro. Dr. Julio Ribeiro is a dermatology registrar at the University of KwaZulu-Natal, South Africa, and a specialist-trained family physician. He completed his undergraduate medical training summa cum laude at the University of Pretoria and subsequently obtained fellowship of the College of Family Physicians in South Africa, together with diplomas in child health, obstetrics and gynecology, and HIV and TB management. Drawing on his background in family medicine, Dr. Ribeiro maintains a strong interest in the psychological burden of skin disease and the broader healthcare systems in which patients receive care. He's particularly interested in qualitative and mixed method research, which explores patients' lived experiences of chronic and stigmatizing chronologic conditions. He completed an M.Med in research and examined the impact of hidradenitis suppurativa on patients' quality of life in South African tertiary care settings, reinforcing his interest in the psychosocial burden of chronic skin disease. So I don't know about you all, but I'm feeling really, really excited to hear from our 2 speakers. And with that, I'll go ahead and let them begin their presentation. Thank you all.
Hi everyone. So my name is Julio and I'm from the university and I'm a dermatology registrar at the University of KwaZulu-Natal, which is based in the seaside city of Durban, South Africa. South Africa is well renowned for its breathtaking landscapes and biodiversity and rich cultural heritage. South Africa is well renowned for its breathtaking landscapes, its remarkable biodiversity and rich cultural heritage. However, despite its beauty, we remain a developing country with significant healthcare challenges, with the Legatum Prosperity Index ranking South Africa 147th out of 167 countries for healthcare. Nowhere are these challenges more evident in the HIV epidemic.
Oh, I'm
For
so
many
sorry.
years,
I'm so sorry, Dr. Ribeiro. We have an audience member telling us that we can't see the slides. We are seeing presenter view.
and what about now?
Yes, now we can see your slides. Thank you.
Okay, perfect. So for many years, South Africa has carried one of the world's largest HIV burdens. Today, we are home to approximately 7.4 million people living with HIV, which accounts for almost 20% of the global HIV burden. So put another way, approximately 1 in every 8 South Africans is living with HIV. Despite this enormous burden, though, we've seen some remarkable progress. So since 2010, the new HIV infections have declined by almost 58%, with an estimated 178,000 new infections occurring annually. So this success is largely attributed to South Africa's extensive public sector HIV program, which provides free access to antiretroviral therapy, along with widespread HIV testing, prevention initiatives, and pre-exposure prophylaxis. Nevertheless, HIV continues to place an immense strain on our healthcare system. From a dermatological perspective, this is particularly significant as more than 90% of people living with HIV will develop at least one cutaneous manifestation during the course of their disease, which can be broadly classified into infectious, inflammatory, drug-related, neoplastic, and iris-associated conditions. Recognizing where a patient fits within the spectrum not only guides diagnosis and treatment, but may also provide valuable insight into their immune status, treatment adherence, and disease progression. As dermatologists practicing in South Africa, HIV-associated skin disease is an integral part of our daily clinical practice. Yet the assessment of skin disease in people living with HIV remains a diagnostic conundrum. On the one hand, there's a risk of over-attributing cutaneous disease to HIV, leading to common dermatological conditions being overlooked. Yet on the other, there's a danger of under-recognizing HIV-associated dermatoses that may serve as important markers for immune dysregulation, treatment failure, as well as opportunistic infections. And navigating this balance is fundamental to delivering accurate diagnosis and appropriate patient care. With this in mind, Professor Mosam and I will be taking you through some interesting cases that we've encountered over the years. I'll begin by discussing 5 cases that illustrate this HIV dermatology conundrum we've just explored and the diagnostic challenges they present. Professor Mosam will then conclude with a rapid-fire interactive MCQ session covering some of the common HIV-associated dermatoses we encounter in our setting and highlighting the key diagnostic and management principles. So let's start with the first case. So just a quick disclaimer before we dive in, this first case is definitely the longest of the 5 because it took us down quite a few unexpected rabbit holes, but I promise the remaining 4 cases are much shorter and much snappier. So the first case involves a 38-year-old female patient of Black African descent who was referred from medicine, under whom she was admitted with a fever of unknown origin. And she was referred for dermatology with the concern of a morbilliform rash of unknown cause. On background history, the patient is RVD positive, but she hadn't been initiated on ARVs yet. And at the time of her admission, her CD4 was 6. 3 weeks prior to this admission, she presented to her local hospital and was admitted with a community-acquired pneumonia after presenting with fever, profound generalized weakness, and shortness of breath. She was treated with 3 days of intravenous antibiotics and subsequently discharged on oral antibiotics to complete a total of a 7-day course. 2 weeks later, though, she represented with the recurrence of original symptoms with a new onset rash. Dermatology was consulted and documented a morbilliform rash involving the face and upper torso. And given the temporal relationship with her recent antibiotics exposure, the eruption was considered most consistent with a cutaneous adverse drug reaction. She was treated with a short course of both oral and topical corticosteroids. However, 2 days later, she presented to the emergency department with persistent symptoms and no clinical improvement. She was found to be clinically unwell with features concerning for septic shock, including a pulse rate of 156, a systolic blood pressure of 98, and a temperature of 42. She was admitted under internal medicine and empiric intravenous antibiotics were started. A comprehensive septic workup was performed to identify the underlying source of infection, including CSF, a throat swab, chest X-ray, echo, as well as a urine MCNS, and also investigations to try to rule out TB, including a chest X-ray, urinary lamb, and a urinary gene expert. Other findings included impaired liver enzymes, eosinophilia, as well as enormocytic anemia with a low reticular production index. Despite intravenous therapy, though, the patient remained persistently febrile, necessitating escalation of antibiotics. An extensive infectious workup failed to identify any causative pathogen, and she was subsequently classified as having a fever of unknown origin. Dermatology was consulted to evaluate whether the accompanying rash could provide a diagnostic clue to explain a systemic illness. So it was only on day 7 of admission that we first reviewed the patient. And at this time, what we appreciated was these widespread erythematous macules and patches, predominantly affecting the face, back, and upper torso, with scattered lesions over the abdomen and lower limbs. We concurred with our colleagues' initial assessment that the cutaneous eruption was most consistent with an adverse drug reaction, with DRESS considered the leading diagnosis. This was based on the morphology of the eruption, the persistent pyrexia, the eosinophilia, and hepatic dysfunction, together with the temporal relationship to recent antibiotic exposure. However, given the severity of the patient's systemic illness, alternative diagnoses were entertained to avoid prematurely attributing a presentation to a drug reaction. So we recommended doing a PCT for the patient, and if negative, to manage as an adverse drug reaction, to also further work up the patient for the differentials we were entertaining, and of course to do a skin biopsy. In the days to follow, the PCT came back negative. Her temperature settled, her CRP came down, and her liver impairment started to resolve. She also reported self-improvement of her symptoms, and subsequently her antibiotics were stopped. But given the resolution of her systemic involvement, only topical ultrapotent steroids were prescribed. With regard to her workup to rule out other causes, pretty much everything came back negative. And when it came to the skin biopsy, there were some non-specific findings, including keratic debris, as well as lymphocytes and plasma cells, in keeping with the drug reaction. The patient's clinical presentation was ultimately considered most consistent with DRESS, and she was discharged from the dermatology service with outpatient follow-up. However, we were reconsulted on day 13 of admission following the development of a new facial rash. And what we appreciated were these new dome-shaped hyperpigmented papules. And given this clinical appearance, we considered lichen myxedematosus as a likely diagnosis. We ordered thyroid function tests for the patient and repeated a skin biopsy with an arrangement made for outpatient follow-up at the dermatology clinic. Given that the patient continued to improve and our outstanding TB tests came back negative, the patient was initiated on first-line antiretroviral therapy on day 15 of admission. However, we were reconsulted on day 21 of admission as the patient had developed sepsis along with worsening of her skin facial rash as well as a new rash. And what we can see in these pictures compared to initial assessment is that these facial rashes were far more numerous and larger, and several were now demonstrating central implication. Examination of the new eruption revealed multiple hemorrhagic papules with surrounding erythema, which was distributed predominantly over the neck, the upper back, and chest, with a few scattered lesions involving the remainder of the body. This evolution of cutaneous findings immediately raised the concern of a deep fungal infection. And in light of the acute change in the clinical picture following antiretroviral therapy initiation, iris was also considered. We requested an expedited histological assessment of the facial lesions that were biopsied on day 13 of admission, with the addition of special fungal stains. We also took a biopsy of the newly developed hemorrhagic papules for fungal culture and PCR. And in view of the high suspicion for disseminated deep fungal infection, we ordered a serum CLAT and urine histoplasminogen antigen and started the patient empirically on amphotericin B. So what we found on the PAS staining of the facial lesions that were biopsied on day 13 were numerous microspherical fungal organisms consistent with the deep fungal infection. These fungal organisms were also readily identified on sections from the biopsy of the newly developed hemorrhagic papules. So these findings prompted us to reconsider the patient's entire dermatological course. So given that the facial papules had initially been misdiagnosed, we questioned whether the patient's original mobiliform rash, previously attributed to DRESS, might instead have represented the initial cutaneous manifestations of a disseminated deep fungal infection. We therefore requested that anatomical pathology re-examine the original skin biopsy, which had been reported as a drug reaction, and on deeper sections, numerous fungal spores were identified, establishing that initial eruption had actually also presented cutaneous involvement of this deep fungal infection. So together, these findings confirm the diagnosis of a disseminated deep fungal infection, providing a unifying explanation for the patient's evolving clinical and cutaneous course, meaning her clinical presentation with community-acquired pneumonia was most consistent with primary pulmonary infection with this disseminated fungal infection, while her subsequent fever of unknown origin represented hematogenous dissemination with sepsis rather than unresolved bacterial infection. And furthermore, the acute clinical deterioration following ARV initiation presented a paradoxical iris. So the identification of fungal organisms in all three biopsies established that each represented a manifestation of the same disseminated deep fungal infection. So remarkably, this patient, over a course of 3 weeks, developed 3 distinct cutaneous morphologies attributed to a single underlying pathogen. So in conjunction with the amphotericin B, the patient was also started on dexamethasone with resolution of her symptoms and great improvement in her skin lesions. Although the diagnosis of disseminated deep fungal infection had now been established, one critical question remained unanswered. Which fungal pathogen was responsible for the patient's remarkable clinical course? And at follow-up 6 weeks later, the results of a fungal culture and PCR performed on the biopsy of those hemorrhagic papules confirmed the diagnosis of Emergomycosis africanus. So this case brings us back to the HIV dermatology conundrum we discussed at the beginning of the presentation. We initially anchored on common diagnoses, a drug eruption, followed by lichen myxedematosus, when in reality this patient had disseminated Emergomycosis. So the first take-home message is this: always keep HIV-associated dermatoses on the table. Don't anchor solely on the common diagnoses we see in the general population. As we discussed in the introduction, HIV-associated skin disease spans a broad spectrum of infections, inflammatory, drug-related, as well as neoplastic conditions. And keeping that broad differential in mind is often what leads you to the correct diagnosis. Another really valuable lesson from this case was the patient's fever of unknown origin. Disseminated deep fungal infections are one of the major opportunistic infections alongside TB that should always be considered in a person living with HIV who has fever of unknown origin. Looking back, had we thought of this earlier, perhaps we could have reached the diagnosis sooner. What also makes this case so memorable is how beautifully it illustrates why deep fungal infections are often called the great mimickers of dermatology. Over just 3 weeks, the same organism produced 3 completely different cutaneous morphologies. Had we seen these eruptions as in 3 separate patients, we would have probably made 3 completely different diagnoses. Instead, this case reminds us that one disease can have many different faces, particularly in people living with HIV. And perhaps the final lesson from this case is that diagnosing emergomycosis requires a high index of suspicion. Clinically, histologically, and even on fungal culture, it can closely mimic other deep fungal infections, particularly histoplasmosis. It is only when the PCR result became available that we were able to confidently identify Emergomycosis africanus. So if you suspect this, remember that molecular testing is essential for definitive diagnosis. So moving on to our second case. This involves a 24-year-old female of Black African descent who was referred from general surgery with chronic perianal abscesses for 3 years, for which she subsequently received a diverting colostomy 2 years prior, and she was referred to dermatology for wound care. She was known with HIV on ARVs, virally undetectable with a CD4 of 819. And what we found were these knife-cut ulcerations involving the inguinal folds, with marked edema of the vulva and perianal erosions. We immediately thought of metastatic Crohn's, but given the retroviral status of the patient, we had to consider opportunistic infections as well. A further history and examination didn't yield any findings to help narrow down the diagnosis, but she had multiple previous investigations done previously, including bloods, which showed an iron deficiency anemia, for which she received multiple previous transfusions for, stool tests, which was positive for occult blood, as well as colprotectin, and she had also had 2 previous biopsies done. The first simply just showing the fistula, but the second showing associated granulomatous inflammation with Langerhans giant cells and negative Ziel-Nielsen and Paz stain. Despite these extensive investigations, no unifying diagnosis had been reached to date. It was only when we integrated the clinical morphology with the granulomatous histology and supported laboratory findings that the diagnosis of extraintestinal Crohn's disease became apparent. So this case highlights the opposite side of the HIV dermatology conundrum we spoke about. While the previous case reminded us not to overlook opportunistic infections, this patient reminds us that HIV doesn't always equal infection. We were certainly obliged to exclude infectious causes first, but once they had been reasonably excluded, we had to broaden our thinking to include inflammatory conditions such as extraintestinal Crohn's disease. One of the biggest clues in this case was the morphology itself. Those characteristic knife-cut ulcerations are a classic feature of Crohn's disease, and recognizing patterns like these can immediately narrow your differential diagnosis and direct your investigations. What I also really liked about this case is that the diagnosis wasn't hidden. It was already there. The patient had granulomatous histology, iron deficiency anemia requiring multiple transfusion, and elevated fecal calprotectin. None of these findings were diagnostic on their own, but when we integrated them with the clinical morphology, they all pointed towards the same diagnosis. So it really reinforces the importance of clinical pathological correlation and looking at the patient as a whole. And perhaps the final lesson is that when a patient has undergone years of investigations without a unifying diagnosis, the answer isn't always another test. Sometimes it's taking a step back, revisiting all the information that's already available, and asking whether everything can be explained by a single diagnosis. In this patient, that's exactly what led us to extraintestinal Crohn's disease. So moving on to our third case. So this involves a 32-year-old male patient of Black African descent who was referred from his HIV clinic with a concern of Kaposi sarcoma after presenting with a 5-month history of a rapidly growing mass on his left thigh. He was diagnosed with HIV 2 years prior on ARVs, virally suppressed though with a CD4 of 254. And what we found was this large fungating indurated plaque on his left thigh. Although the patient was referred with a provisional diagnosis of a Kaposi sarcoma, our primary concern was for a cutaneous lymphoma or a sarcoma, or possibly a metastatic malignancy involving the skin. He reported B symptoms and exertional dyspnea on extended history and systems inquiry, and clinically we found subconjunctival pallor as well as multiple palpable lymph nodes and hepatosplenomegaly. Blood showed a pancytopenia with a low reticulocyte production index, and his chest X-ray showed higher lymphadenopathy, and his abdominal ultrasound showed an homogeneous hepatosplenomegaly and lymphadenopathy. So everything seemed to be fitting together and pointed towards a malignancy, until the histology report completely changed the direction of our thinking, as the PAS stain showed these microspheres measuring 5 to 9 microns, suggestive of a deep fungal infection, with the markers strangely negative for lymphoma. Subsequently, the histology was signed off as histoplasmosis, but as you know, a deep fungal infection hadn't even featured on our original differential list. Nevertheless, we reluctantly commenced amphocericin B while simultaneously buying ourselves time to repeat the biopsy and pursue a fungal culture and PCR to either confirm or refute the diagnosis. And this second biopsy painted a completely different picture. This time, atypical lymphocytes were identified, which stained strongly for CD30. But interestingly, the PAS stain once again highlighted these same microspheres that had been initially interpreted as histoplasmosis. However, now in the context of the repeat biopsy demonstrating atypical CD30 positive lymphocytes, these structures were instead recognized as what is known as Hamazaki-Weissenberg bodies. So these bodies were first described in sarcoidosis, but have also been reported in association with lymphoid neoplasms. And a very useful way to distinguish them from fungal spores is to do what's known as a Montana-Mason stain. So because they contain melanin-like pigment, your Hamazaki-Weissenberg body will stain positive with Montana-Mason, whereas your fungal organisms won't. So based on this repeat biopsy, the diagnosis was revised to CD30 positive non-Hodgkin's lymphoma, a diagnosis that finally made sense of the clinical picture. Subsequent investigations were undertaken and the patient to determine the stage, and the patient was referred to oncology. So this case again highlights that HIV dermatology conundrum we discussed earlier. So faced with a person living with HIV and a rapidly enlarging violaceous tumor, it's very easy to jump to the obvious HIV-associated diagnosis, Kaposi sarcoma. However, this case reminds us that people living with HIV can develop exactly the same dermatological diseases as everyone else. So HIV should broaden our differential diagnosis and not narrow it. The second lesson is that not every violaceous lesion in a person living with HIV is Kaposi sarcoma. Our patient was referred with a provisional diagnosis of KS, but this was never our leading differential. Clinically, the lesion looked much more like either a primary cutaneous lymphoma, sarcoma, or cutaneous metastases. So the take-home message is simple. Don't let HIV or the color of the lesion dictate your diagnosis. Every patient deserves a fresh clinical assessment and an independent differential diagnosis. And then thirdly, perhaps most importantly, clinical pathological correlation remains essential. Although the initial biopsy suggested a deep fungal infection, it just simply didn't fit the clinical picture we were seeing. Had we accepted the pathology at face value, the patient's lymphoma may have remained undiagnosed until a much later stage, which with potentially devastating consequences. The pathology must always make sense in the clinical picture. And then finally, don't be afraid to challenge your diagnosis. When the clinical findings and pathology don't align, trust your clinical judgment. Re-biopsy the patient, reopen the conversation with your anatomical pathologist, and continue searching for an explanation that makes sense. Moving on to the fourth case. This involves a 40-year-old female patient of Black African descent who was referred from an HIV clinic with a 1-month history of an extensive rash. She had been diagnosed with HIV 3 years prior and on ARVs with a viral load lower than detectable and a CD4 of 316. And what we found on clinical examination were these widespread annular scalding parts with central post-inflammatory hyperpigmentation. Our main concern here was most likely infection, either secondary syphilis or extensive tinea corporis. But we also entertained a possible lichenoid drug eruption or annular lichen planus. A further history and examination, though, didn't yield any findings to help narrow down the diagnoses, and a syphilis serology came back negative. Her skin biopsy demonstrated an interface change with some scattered necrotic keratinocytes, together with superficial and deep perivascular and periadnexal lymphocytic infiltrates, collectively in keeping with a lichenoid interface dermatitis. Overall, these findings were best fitted the clinical picture of a lichenoid drug eruption. Although the patient denied any newly initiated medications, we recognize that in the South African public sector, antiretroviral formulations frequently change as different manufacturers are awarded national tenders. So while the active ingredients remain the same, the excipients may differ, and we had encountered similar cases previously. We therefore considered her antiretroviral therapy the most likely culprit and consulted infectious diseases who recommend discontinuing her heart as a diagnostic trial. We also gave oral glucocorticosteroids due to the extension of the lesions. And 1 week post-steroid initiation showed marked clinical improvement, and the prednisone was subsequently weaned and discontinued after 4 weeks. However, 2 weeks post-cessation of her steroids, she developed an acute flare, despite having been off her heart now for 6 weeks. And what we now appreciated were these abraded erosions involving the malar area and via of the neck, along with vasculitic patches over the lower legs, as well as targetoid lesions on the hands. These findings were highly suggestive of subacute lupus, further supported by the observation that the rash improved with prednisone therapy and subsequently faded following its withdrawal. She didn't report, though, any typical systemic manifestations of lupus, but her anti-Ro and anti-LAR came back positive. Her urine dipstick was negative, and her skin biopsy showed the same findings as before, a lichenoid interface dermatitis. But given these new cutaneous findings and positive autoantibodies, the diagnosis was thought best to be in keeping with subacute lupus. We subsequently restarted an antiretroviral therapy along with prednisone and hydrochloroquine and saw great improvement clinically. So this brings us back again to that HIV dermatology conundrum. Having excluded infections, we naturally gravitated towards one of the most common inflammatory dermatoses we encounter in patients living with HIV, a lichenoid drug eruption. But based on the clinical presentation, histology, and the South African context of changing antiretroviral formulations, it wasn't entirely reasonable working diagnosis. The second lesson that we can learn from this case is that it was an entirely reasonable diagnosis that we made in this patient, as it explained the patient's presentation at point in time. However, when the patient relapsed, despite having been off therapy for 6 weeks, it became evident that our working diagnosis no longer explained the clinical course. Recognition when the diagnosis no longer fits is just as important as making the diagnosis in the first place. That naturally brings me to the next lesson. So the clinical course is often one of the most valuable diagnostic tools we have. A patient's response to treatment can either strengthen or weaken your confidence in a diagnosis. When a patient fails to respond as expected or relapses despite appropriate management, don't simply escalate treatment. Stop, reassess the patient, and ask yourself whether you've got the diagnosis right. And that's exactly what happened here. Revisiting the patient revealed new clinical clues, including the malar erosions, the vasculitic lesions, and the positive autoantibodies, which ultimately pointed towards subacute lupus. It also reminds us that although autoimmune diseases are less common in advanced HIV, they can and do occur and should always remain part of the differential diagnosis. So moving on to the last case. This involves a 42-year-old male patient of Black African descent who was referred from his HIV clinic also with a concern of possible Kaposi sarcoma after presenting with a 5-month history of these painful violaceous plaques on the hands and elbows. He was diagnosed with HIV a year prior but hadn't been initiated on antiretroviral therapy, and at the time of presentation had a CD4 of 345. And what we appreciate on clinical exam with these hyperpigmented violaceous indurated plaques on both dorsums of the hands as well as the elbows. And he also had these hyperkeratotic changes over both palms. Although we weren't particularly concerned for Kaposi sarcoma, a differential diagnosis remained broad, encompassing deposition disorders, granulomatous disorders, as well as neutrophilic dermatoses such as erythema elevatum diatinum. A further history and examination didn't yield any findings to help narrow down the diagnosis, and all his bloods were normal. His biopsy, though, showed classic signs of leukocytoclastic vasculitis with a perivascular inflammatory infiltrate of neutrophils and associated fibrinoid necrosis. There was also a spindle cell proliferation that was human herpes virus 8 negative, but CD68 positive, in keeping with the reactive fibrohistiocytic proliferation rather than Kaposi sarcoma. And taken together, this cumulative finding was in keeping with EED. We subsequently investigated the patient for associated systemic disease and potential underlying causes rather than simply attributing the condition to HIV. The patient was then started on systemic dapsone therapy. So this final case really brings together the presentation full circle. Once again, we were faced with a person living with HIV and a violaceous eruption. Once again, it would have been very easy to label it as a Kaposi sarcoma, but just like the previous case, HIV should broaden our differential diagnosis, not narrow it. In reality, Kaposi sarcoma wasn't a major concern for us. Instead, we considered a broad range of inflammatory, granulomatous, and deposition disorders. This case reminds us that not every violaceous lesion in a person living with HIV is an HIV-associated dermatosis. So what ultimately gave us this diagnosis was the biopsy. Clinically, several conditions looked plausible, but it was the histopathology that demonstrated leukocytoclastic vasculitis and a reactive fibrohistiocytic proliferation that helped point us in the direction of EED. So it's just a reminder that when the diagnosis isn't obvious, biopsy early. It often completely changes the direction of your thinking. And the final lesson is that making the diagnosis isn't the end of the journey. Once we had diagnosed EED, we didn't simply start dapsone and move on. We investigated the patient for associated systemic disease and underlying causes before initiating therapy. So good dermatology doesn't stop at naming the disease. It asks why the patient developed it in the first place. So what we've seen today is the greatest challenge in HIV dermatology is often not recognizing rare diseases, but avoiding diagnostic anchoring, whether we're anchoring on HIV itself, infections, a referral diagnosis, histopathology, or our initial clinical impression. The key is to continuously challenge our thinking, maintain a broad differential diagnosis, and always ensure that the history, examination, investigations, and pathology tell the same story. I hope these cases have provided some practical framework for approaching skin diseases in people living with HIV. And with that, I'd like to hand over to Professor Mosam, who will test us on some of the common HIV-associated dermatoses we encounter in our setting through a rapid-fire interactive MCQ. Thank you.
Thanks, Julio, and good afternoon, everyone. Right. So what I'm going to do is take off where Julio has left off and go through a number of cases to show you practical lessons around what we manage. And instead of a didactic discourse, I thought a case presentations would illustrate the nuances of managing patients with HIV. And it would be something that residents could then read around once they've seen a case rather than hearing about it. Okay, so the first case is that of a 13-year-old teenager with asymptomatic facial, an asymptomatic facial and truncal eruption of these hypopigmented flat top papules and plaques displaying kubnerization. Okay. Am I audible and the slides okay? Are they all visible?
Yes, we can see your slides.
All right. So the following are true regarding this condition. It's associated with horizontally transmitted HIV. True, false? False. Okay. It's associated with vertically transmitted HIV. The histology reveals keratinocytes with pale staining cytoplasm and vacuolated nuclei. True. Okay, so we're dealing with a viral infection, and what it's showing here, inclusion bodies within the keratinocytes. So which HPV types are most commonly associated? 5, 20, and then 8. All right, so you all know what we're dealing with here. It's acquired epidermodysplasia verruciformis in immunosuppressed individuals with HIV. And the cornerstone to management, cornerstone of management is optimizing heart. That's false. These patients are usually very well controlled on antiretrovirals, and optimizing antiretroviral therapy does not have any bearing on the skin lesions. They usually need topical therapy with keratolytics, sometimes retinoids, long-term to prevent them developing further skin cancers. Usually it's in a sun-exposed distribution, which is why they need sun protection and prevention of the development of skin cancers. Okay, this is a young lady who presented with persistent pruritus, worse at night, revealing extensive excoriations and hyperkeratotic plaques involving the elbows, knees, dorsa, hands, and feet. Okay, so the following are true regarding this condition. Dermoscopy reveals a delta wing jet sign. Okay, so no prizes for guessing. We're dealing with scabies. Okay, 5% permethrin is the first-line treatment. That's true. Usually that is the first-line topical therapy and is quite effective. The treatment of choice is ivermectin at 200 micrograms per kilogram. That's true in crusted scabies, usually given in epidemics, in institutionalized patients, because these patients are riddled with thousands of mites, and it's usually given as a stat dose and then 14 days later. The commonest complication is post-streptococcal glomerulonephritis. That's false, okay? So the commonest is post-streptococcal infection, staph infection, impetigo, but in a subset of individuals, they can develop chronic complications in terms of glomerulonephritis as well as cardiac disease if the secondary infection is not adequately treated. So it's very important to recognize these patients and to treat them timeously. Okay, the next case is that of a 32-year-old male with an erythematous scale eruption involving the trunk, the extensors, and has dusky papulonodular lesions of the soles. Okay, so the following are true regarding this condition. Histology reveals lichenoid inflammation with endothelial swelling and plasma cells. True. A negative RPR excludes a diagnosis of syphilis. That's false, okay? So if you have a strong suspicion of secondary syphilis, and you've got a negative serology, consider the prozone phenomenon, let them do dilutions until you get, and that should overcome the prozone and give you a positive RPR. An RPR of more than 8 indicates active disease. That's false, right? In the setting of HIV, usually more than 16, because patients can have a positive RPR for life. And intramuscular benzathine penicillin is the drug of choice. That is true. Okay, the same patient now was given, was started on heart. He had a very low CD4 count of 25, and he had worsening of this rash after starting heart. You can see it's the same patient, more extensive lesions on the trunk as well as the palmar surfaces. The following are true regarding this condition. A mobiliform drug reaction to penicillin is most likely. Not impossible, but very unlikely given the timing in this patient. Also that they're unlikely to mount a response. This is a manifestation of paradoxical iris, okay? So that's true. Patient started on heart and had an exaggerated reaction in keeping with a paradoxical iris. An important risk factor is a CD4 count of greater than 100. That's false. CD4 count of less than 100 is a risk factor. And an iris can occur a few weeks to several months after initiating HART. That's true, given whenever there's successful antiretroviral therapy accompanied by a drop in viral load and an increase in CD4 count, that is when an iris will occur. And in some cases, it's rare, but it can even take a few years. Okay, the next case is that of a young adolescent with this erythematous scaly eruption. You can see the background, erythema. In fact, he's erythrodermic. And then with well-defined psoriasiform plaques involving the extensors with palmoplantar keratoderma. So the following are true regarding this condition. Phototherapy and acitretin are the most effective first-line therapies. That's true. Immunosuppressants are contraindicated due to the low CD, due to the low CD4 counts that are associated. That's false. It can be used with caution. Certainly, immunosuppressants can be used if patients are on successful antiretroviral therapy. Pathogenesis is related to a decreased CD4-CD8 ratio. That is true in HIV-associated psoriasis. And lastly, interleukin-17 inhibitors are most appropriate in a TB endemic environment. That's true. Right? So TNF-alpha inhibitors are very successful, but in a TB endemic environment, interleukin-17 inhibitors are safer. Okay, this is a child who presented with asymptomatic hypopigmented patches on the face, on the arm as well, some nodules on the face, and a very distinct edge of one of the patches that had become visible. So the following are true regarding this condition. Biopsy with a phyte stain is the most appropriate investigation. True. The prevalence of leprosy has increased due to HIV. That's false, okay? The prevalence of leprosy has remained the same, but the reactions have become more prevalent. Yes, the reactions are more prevalent due to HIV for various reasons. In our setting, sometimes it's associated with initiation of anti-TB therapy, and with rifampicin-based regimens, there could be upgrading reactions. Type 1 reactions require long-term prednisone. That is true. Sometimes the reactions can go on for a long time, and they might need long-term steroid therapy. This is an ill child with GI symptoms, inability to eat due to oral lesions with ulcers around the mouth. Okay, HIV positive and had not initiated antiretroviral therapy. The most likely diagnosis is HSV ulcers. These are possible. Those are usually painful. However, there was a therapeutic trial with antivirals with no response. Atypical mycobacterial infection, very unlikely given the site of these lesions and in a child. TB cutis artificialis. This is seen in patients with low immunity. These are usually teeming with acid-fast bacilli. Okay, and that was the diagnosis in this individual with a GI involvement and with the ulcers that were peri-orificial. Pyostomatitis vegetans, that is possible in the presence of inflammatory bowel disease. However, in the setting, there was histology and culture that would prove the diagnosis of tuberculosis. This is a young adult who presented with asymptomatic, well-defined papules and nodules involving the face, the ears, the elbows, and grouped follicular papules on the trunk. Most likely diagnosis is micropapular sarcoid, very unlikely, unusual in HIV. It's not impossible to get sarcoidosis, but rare. Papulopruritic eruption of HIV. This is usually itchy. There's excoriations. There's background post-inflammatory hyperpigmentation, and usually there's relapses and remissions. Papulonecrotic tuberculate with lichen scrophulosaurum. So this is seen with underlying tuberculosis. There's acral predominance of the lesions, asymptomatic, and lichen scrophulosaurum usually has, they're grouped follicular papules associated usually with underlying nodal TB, as well as bony TB. Mobiliform drug eruption, unlikely in this individual. Okay, this is another child with known with HIV TB, presenting with a lichenoid eruption on the face, the trunk, the limbs, but worse, involving the sun-exposed sites. Most likely diagnosis is a lichenoid photodermatitis of HIV, possible, certainly possible in advanced HIV. Leukomelanoderma of HIV, this is a specific entity where there are depigmented areas involving especially the sun-exposed areas, unlikely in this patient. Lichenoid dermatitis secondary to antituberculous therapy is the most likely cause in this individual, and something we see with the use of anti-TB therapies, and very, very difficult to manage as well. Lichen planus, unlikely. Okay, this is a case of a patient not on heart, advanced retroviral disease, presenting with molluscum type lesions, as well as violaceous patches involving various sites. And we can see on the face large papulonodular grouped lesions involving the central area of the face. Most likely diagnosis is giant molluscum contagiosum, possible. Okay, but we don't see that central cheesy core. Molluscum contagiosum and Kaposi sarcoma, certainly possible, especially in advanced HIV, to see dual pathologies. However, again, we're not seeing the central cheesy core, and we're seeing that hemorrhagic crusting, which we don't see in molluscum contagiosum. B-cell lymphoma and Kaposi sarcoma, again, unusual, with facial involvement and the large papulonodular lesion on the face. And lastly, cryptococcosis and Kaposi sarcoma, right? So here we see the molluscum type lesion, which is very, very typical for systemic fungal infections, the hemorrhagic crusting, overlying, and in a patient with advanced retroviral disease, disseminated fungal infection with an HIV-associated malignancy. Okay, this case was a young lady who presented to us with extensive plaques and crusting, predominantly facial, as well as involving the upper central chest with palmoplantar keratoderma. And some areas on the trunk are very, very well-defined plaques that are psoriasiform. This was after therapy with keratolytics and retinoids, and we can see the central chest involvement and the healing with post-inflammatory hypopigmentation. Most likely diagnosis is Lewis maligna and HIV. It's always a consideration in HIV. We always have to think about secondary syphilis. However, an RPR was negative in this case and would easily exclude that diagnosis. Atypical psoriasis and HIV, always a possibility. But again, here it was the facial involvement and the seborrheic area involvement which clinched the diagnosis of type 6 PRP. Exfoliative dermatitis, unlikely with the extent of this disease. Okay, this case was that of a patient with advanced HIV, not on heart, presenting with hyperpigmentation. We can see some scarring involving the dorsal of the hands and blisters on the palmar surface of the hand. So, chronic actinic dermatitis in HIV, possibly, but not with blisters on the hands and involvement of non-sun exposed areas. The pathogenesis is a deficiency of uroporphyrogen decarboxylase. Obviously, we're dealing with porphyria cutanea tarda here, so that is true. An appropriate bedside investigation is Wood's lamp examination of the urine. That will definitely show us the pink fluorescence of the porphyrins, and chloroquine twice weekly is effective therapy. That is true. PCT in HIV, very often these patients do have anemia, and therapeutic phlebotomy is not always possible, so the twice weekly chloroquine is extremely effective. Patient with ulcerated tumor on the arm, as well as a psoriasiform plaque and another annular lesion with central clearing. Most likely diagnosis is pyoderma gangrenosum in HIV. We're not seeing any cribriform scarring, unlikely. Lewis maligna, again, distribution is atypical. Kaposi sarcoma, we're seeing a plaque, but it's very erythematous and more psoriasiform than really violaceous. B-cell lymphoma is the answer, okay? So tumors, plaques, a variety of different lesion types in one. And of course, histology and special stains will clinch the diagnosis on this. Okay, patient presenting with annular circinate lesions with central clearing. Patient is on heart. Most likely diagnosis is, again, this is very similar to the case that Dr. Ribeiro showed you. Secondary syphilis, always a consideration, but WR, TPHA were negative. Giant annular lichen planus in HIV, possible. Tinea corporis, KOH scraping is negative. And the case here was a giant annular drug eruption secondary to antiretroviral therapy. In this case, specifically, it was efavirenz. And that was his response after he had a structured treatment interruption to his antiretroviral therapy. Okay, almost getting to the end. This is a patient with, again, advanced retroviral disease who presented with these erythematous papules and nodules. You can see them on the face, on the trunk. They're quite extensive. The patient was quite ill, also with a pyrexia of unknown origin. And the following are true regarding this condition: multiple pyogenic granulomas in HIV. Yes, this is a possibility, but given that the patient is sick, it's unlikely. Histology reveals capillary proliferation lined by plump endothelial cells with neutrophilic debris. So that would be possible if he was just a pyogenic granuloma. Since we have these plump endothelial cells and neutrophilic debris, we have to think of an underlying organism, and most likely this organism is a spirochete which stains positively with silver stains, and this is Bartonella henselae. So we're dealing with bacillary angiomatosis, and therapy with doxycycline can be used as a therapeutic trial. And we would often use this to differentiate between Kaposi sarcoma and bacillary angiomatosis. Okay, so this is a patient who was quite challenging to manage. He had a very low CD4 count. He was CD4 was 25. He was failing antiretroviral therapy, and multiple therapies did not make a difference to him. He had imiquimod, salicylic acid, PDT was unaffordable, surgery was deferred due to the low CD4 count, and because of the virologic failure, his heart regimen was changed. He then presented to us with enlarged lesions of molluscum contagiosum involving the face, the scalp, the groin with secondary infection, and he was diagnosed with paradoxical iris and treated symptomatically, admitted, given intravenous antibiotics, and over time, the lesions resolved and heal with complete regression and scarring. So this was a paradoxical iris in a patient with recalcitrant molluscum contagiosum, and even though his CD4 count did not increase, qualitatively, they improved, and that's how we explain he had regression of these lesions, which highlights one of the important cornerstones of managing iris, that when one has to encourage the patient to adhere to their antiretroviral therapy whilst their secondary pathology is being treated. And this is the final case that I'm going to share with you, is that of a young HIV positive model whom we treated, who presented with ulcers on the neck of a few years duration. Her CD4 count was 335 and her viral load was undetectable. She was on heart. The working diagnosis here was that of an HSV iris, treated with multiple courses of antivirals. She was even admitted for IV antivirals without response. All her cultures had been negative. And the lesions progressed. As they progressed, she developed an iron deficiency anemia, hypoalbuminemia, and her biopsy was in keeping with a pyoderma gangrenosum. She was treated with prednisone, as well as anti-neutrophilic agents like colchicine, as well as doxycycline, without any improvement. Eventually, it was noticed that, how linear the lesions were, how clean they were. She had this very flat affect, and she was eventually admitted to creating these lesions. She was eventually diagnosed with dermatitis artifacta and did well on psychotherapy and antipsychotics. Okay, so in conclusion, I'm just going to share with you a few parting comments on managing patients with HIV. The first is that we've seen a shift in the spectrum of dermatosis in HIV in the heart era. So obviously, initially, we were dealing with AIDS-defining condition, and infections and tumors predominated the spectrum. Now it is mainly non-infectious inflammatory conditions which have become more common. When we see infections, the common ones are still the fungal and viral infections. In evaluating persons living with HIV, and you've seen this through all of the cases, certainly the ones that were presented by Dr. Ribeiro, how a thorough history, a travel history, a systemic, evaluating systemic symptoms, looking at all the pointers to HIV control, the CD4 viral load, all the other sexually transmitted diseases, but also biopsy, repeat biopsy, and biopsy and culture are absolutely important in clinching significant diagnoses timelessly. So one has to also keep an open mind for multiple etiologies, look at biopsy and specifically biopsy and culture in order to be able to pin down the etiology and the organism that needs to be targeted. A multidisciplinary team is essential for holistic management. So the physicians, the ID physicians, the pathologists, the virologists, and the microbiologists, as well as the psychologists and psychiatrists, are all important in managing these patients effectively. And that HIV plus skin disease usually, we must consider HIV dermatoses, and these range from seroconversion illness to all the infections, inflammatory conditions, as well as the drug reactions and the iris, those conditions that present with the iris manifestations. And then certainly we need to think about a dermatosis in somebody who is coincidentally HIV positive. So with that, I'm going to close here. I think I've gone over my time. I'm going to leave you with some of the references that Dr. Ribeiro and I have used in drawing this up. And I thank you for your attention.
Thank you so much. I just wanted to give a thank you to our wonderful speakers today and the insightful discussion that we had. Just because we are at the top of the hour, one question we just wanted to ask is, what is one key takeaway you'd like people from this webinar to implement in their training and practice?
So the key takeaway would be to keep an open mind in terms of treating an HIV positive patient. Do not let HIV cloud your judgment. Before slotting them into a what's the word, Julio? Into a box, thinking only about HIV. I think just think broadly, look at the lesions, think about what they could be before, considering this is an HIV-related dermatosis.
Thank you very much, Dr. Mosam. Dr. Ribeiro, any key takeaways?
So probably the two key takeaways would be that, again, if the histology is not in keeping with what you're suspecting clinically, to always take the initiative to stick to your guns and re-biopsy or reinvestigate the patient, because ultimately it's what we ultimately want to look after the patient long term. And then probably the second key take-home message is to always keep a broad differential diagnosis when facing.
So there's something else I just want to jump in here. I think one of the things is to go with your gut. If you think clinically you suspect something, stick with that, and investigate the patient, because, I think 9 times out of 10, you probably would be correct.
Wonderful. Thank you. So unfortunately, we are at the end of our time here. If any of our guests need to step away, that's totally fine. But just to close out our session, as Natalie said, thank you all for attending today. If you'd like to learn more about Glowderm or see a recording of this presentation in case you aren't able to stay for the full hour, you can find us on our username is @Glowderm Alliance on various social media channels. A big thank you to our supporters, CeraVe Care for All and the Ellis Foundation. A big thank you to our co-hosts, Natalie and Sabali, to our program coordinator, Alexis, and of course to our wonderful speakers, Dr. Mosam and Dr. Ribeiro. Thank you, everyone. Have a great rest of your morning or afternoon or evening, and we'll see you next time.
Questions here.